This is a talk for Adler Graduate School, course number 537, Advanced Counseling Skills. It is about evidence-based practice, and it is a talk that I gave at the North American Society of Adlerian Psychology annual conference in 2020. By the end of this talk, you should be able to distinguish between an empirically supported treatment, EST, and an evidence-based practice, EBP. You should also be able to identify 3 resources for identifying an empirically supported treatment and be aware of a way to evaluate empirically supported treatments for congruence with the core constructs of individual psychology. We'll start by going over some definitions, and then we'll look at the concept of best available evidence and mindful integration, which are core ideas in evidence-based practice. And finally, we'll talk about the individual psychology empirically supported treatment rating scale. So let's start with some definitions. An empirically supported treatment begins with a treatment and asks whether it works for a certain disorder or problem under certain specified circumstances. There are generally 7 criteria for a treatment considered an evidence-based intervention. Using a randomly controlled trial based on several samples, having a clear definition of the variables and the interventions, the feasibility of that intervention for use in a natural setting, and some sense of fidelity, a notion that interventions can be implemented ethically. The theoretical foundation is clearly stated and adhered to. And finally, that it addresses diversity. These came from Smith, 2014. A lot of people are also talking about the need to include functional outcomes in the empirical evaluation of a treatment. On the other hand, an evidence-based practice starts with the client and asks what research evidence, including the relevant results from randomly controlled trials, will assist the psychologist or counselor in achieving the best outcome. And this comes from a mindful integration of valid and reliable assessment techniques, comprehensive case formulations, and empirically supported treatments. It's important to look at the client perspective as well as the clinical expertise. I think it is important to remember that each of us, each person, is totally unique, is also like some people, and is like all people. And this is a continuum. On the left-hand side of that continuum is where individual psychology fits, and in the middle there somewhere is where the diagnostic and statistical manual fits, and where empirically supported treatments fits. Strategies for using empirically supported treatments in therapy have become more sophisticated and increasingly adapted to naturalistic settings. We have to adapt those empirical supported treatments to the situation that we are in. There are a number of different types of research evidence that are available to the clinician. A meta-analysis, randomly controlled trials, and then research that's conducted in a naturalistic setting, and various ethnographic research. There's increasingly single case experimental designs and single case studies, as well as systematic case studies, and then qualitative research and clinical observations. You might, for example, consider seeking out a consultation from somebody who has more experience as a type of research evidence. You can find this evidence from different websites. I've listed in the handout several websites that have empirically supported treatments that have met the specified research criteria and that are geared to various diagnoses. There are also some standards of care that are available for different professions and a number of review articles that increasingly can integrate a number of studies into and make them applicable to our particular specific practice. As we make treatment planning decisions, it is important to keep in mind that clients have a perspective, they have preferences, and then there are characteristics that might indicate or contraindicate certain treatments, and then it's important to consider culture in that incorporation of the client perspective. This requires very careful listening and attending to the client and what they're saying. The third corner of the empirically based practice triangle is clinical expertise. This is something that it is our responsibility to continue to develop across our careers. We need to have expertise in assessment, diagnostic judgment, case formulation, treatment planning, and a theoretical orientation. I think there's a considerable amount of interpersonal expertise that's involved here, as well as a continual lifelong self-reflection and acquisition of skills that is imperative for a good clinician. We have responsibility for understanding the influence of individual, cultural, and contextual differences on treatment and on treatment planning, and a responsibility to seek available resources, including supervision and consultation in that process. I have proposed this rating scale as a way to evaluate the level of agreement or congruence of an empirically supported treatment with the core constructs of individual psychology. I base that on my 10 core constructs that I identified for individual psychology, and then use a rating scale for each of the 10 core constructs, and they're rated on a 10-point scale, so that 1 is explicit language in the empirically supported treatment is contrary to or unsupportive of individual psychology, of that construct of individual psychology. And 10, the other end of the scale, is explicit language in the empirically supported treatment that is supportive of and agrees with that core construct of individual psychology. This ends up with a score that ranges from 10 to 100, where 100 is perfect congruence with individual psychology core constructs, and 10 is no congruence. Here are the 10 core constructs that I identified for individual psychology. Here are those 10 constructs that I identified as the core constructs of individual psychology.